Bismillah ar-Rahman ar-Rahim. Good evening. Our lecture today is about history taking in psychiatry. Before I start, I would like to say some points about psychiatric interview. Psychiatric interview is used for obtaining information, observing the patient in two-person interaction, and giving support. Also, it used to assess the patient emotional state, any psychological and social phenomena. Also, we are looking for any significant events in the life of the patient. In addition to that, we must understand the patient experiences and his attitudes toward a variety of people and circumstances. In fact, the total interaction between doctor and patient is a most important source of information. So any stereotyped questioning must be avoided, and the examiner must be warm, empathic, and responsive. Comments which make the patient realize he is being understood are likely to increase his confidence. The interviewer must be alert to the implications of the patient's facial expression, his tone of voice, and his command and gesture. Also, the flow of the interview depends on what the patient says, but the examiner is in control. The examiner must have a clear idea of the range of information he wants so that he can guide the interview from one subject to another until he is satisfied that everything has been covered. General interview skills. We start by greeting the patient, then you should introduce yourself and explain the nature of the interview. Then tell the patient that you are going to find out some detail about himself and his life and what has been happening to him recently. Then explain the confidentiality and tell him that you may write things down. Also, getting verbal consent is very important to start the interview. Then you should establish a rapport with the patient as possible. Also, the examiner should be silent during the interview with active listening. Also, the other point are very important and should be put in our consideration. The history should be elicited from the patient and from one or more informant. The informant may be relative, neighbor, friends, or police. Only in exceptional circumstances should the informant be interviewed before patient. Information from the patient and from different informant should be kept and recorded on separated sheet. Also, you should record your impression about the informant reliability and his attitude to the patient and to the illness. Although sex can be known from patient's name, but some names are fusing. We are looking for any gender identity disorder. Also, there are diseases related to the female like premenstrual dysphoric disorder, postpartum psychosis, and some diseases are more common in male like substance abuse, antisocial personality disorder, and other are more common in females like depression and conversion disorder. Some diseases are related to age. Senile dementia and Alzheimer's disease are related to old age. Hysteria and psychotic disorder are more common in adulthood. Also, dosage of drug depends on patient age. Prevalence of mental disorders is as follows. Divorce more than single. Single more than the widow. Widow more than the married. Although some studies show that it is more in single than divorce. Homeless persons may be cause or result of mental disorder. And the distribution of disease may vary in urban and rural communities. Also, residence is important for follow-up of the case. Unemployment is associated with psychological distress. Occupational skills may be impaired by patient's symptoms. Also, occupation may be etiology of intoxication by heavy metals. In addition to that, occupation is a good indicator for socioeconomic state and level of intelligence. The source of referral may be the patient himself, or a relative, or a friend, or the police. The reason for referral may be treatment or incompliance of medication or medico-legal reasons. Chief complaint reported by patient in his own words, and the duration of each complaint should be mentioned. Example, decrease appetite since 10 days, decrease sleep since 5 days. So it should be written in verbatim, no matter how absurd, illogical, irrelevant, or bizarre it is. Due to impaired insight of psychiatric patient, it is important to take the informant's complaint. Present illness is very important in taking history. The onset of the disease may be acute or subacute or gradual. Also, the course of illness may be continuous, episodic, or fluctuating. The duration should be mentioned: days, weeks, months, and the intensity of the disease, either same or increasing or decreasing, also should be mentioned. We are looking also for precipitating factor or any predisposing factor. Also, if there is the history of current episode is very important. You should explain in detail regarding the presenting complaints. Also, if there is any associated disturbances like medical problems, disturbance in sleep, in appetite, sexual relationship, social functioning, occupation, all of these should be mentioned. History should be recorded as far as possible, so we record dates of illness, symptoms, diagnosis, treatment, and any hospitalization and any compulsory treatment under the Mental Health Act. Even the name of the hospital, name of the doctor should be mentioned. So we are looking for any similar or other psychiatric problems in the past. Family history, it is very helpful to draw a picture of the patient family using squares for males and circles for females. Those who have died are indicated by an oblique line through the circle or square, together with the date of death and cause of death. A double oblique line indicates marriage ended by divorce. We should ask about mother, age, mental and physical illness or illnesses, personality, and patient relationship. If she is died, so you should ask how old the patient at the time of her death. The same information for father should be taken. Regarding the SIBs, we should enumerate in chronological order of birth, with first names, age, marital state, occupation, significant illnesses, personality, and the important thing is the patient previous and current relationship with them. Also, we ask about familial disease, alcoholism, abnormal personalities, mental disorders, and epilepsy in other relatives. Regarding the family atmosphere in childhood, we're asking about emotional relationship within the family. Any early stresses arising from emotional or economic causes, including the death or separation from the close relative and the patient at that time. Early development since the birth of the child of the patient, behavior and illness during the childhood. We ask many questions, or we are looking for something like persistent sleep difficulties, bedwetting, stammering, hyperactivity, truancy, also respond to the birth of the SIBS, separation from parent, excessive temper tantrum, if there is any history of CNS infection, malnutrition, or epilepsy. About school, we ask about the age of beginning and finishing, types of schools, examination passed or failed, if there is any specific difficulties, the attitude toward peers or teachers, and work. Also, we should look for learning disabilities, attention deficit, and look for conduct disorder. Example, truancy, stealing at this period. Occupations. We ask about the age of starting work. Usually we mention the jobs in a chronological order, and if there is any change, we should ask about that change and why. Also, the relationship with superiors, subordinate, and colleague. And if there is satisfaction in work, or reason for dissatisfaction, and also we ask about the competence. Adolescence. Attitude is very important to the growing up, to peers, to family, and to authority. Also, we're asking about any drug taking or period of depression and fantasy life. Sexual history. The age at onset of puberty is very important. We can ask or looking for any sexual deviation, sexual disorder, or sexual dysfunction. Also, we ask about extramarital relationships and if the sexual satisfaction is present or not. Marital history, number of previous engagement, duration of courtship, also the age at marriage, age, occupation, health, and the personality of marital partner. Also, the important thing is the marital relationship and the problems in the past and at present. So the fidelity of partner is very important to be asked. Children. Chronological list of pregnancies is names of children, their physical and mental health in the past and at the present time, state, place, and time of psychiatric treatment received by children, attitude toward the children, and further pregnancies. Medical history. We ask about the health during childhood, any menstrual abnormalities, and also we ask about illnesses, operations, head injuries, accidents, hospitalization in chronological order. Use and abuse of alcohol, tobacco, and drugs. We are looking for any evidence of effects of the drug or alcohol on health, relationships with others, and ability to work effectively, and finances. Also, we ask about the use of cannabis, LSD, amphetamine, or heroin, and any history of dependence on hypnotic or forensic history. We ask about antisocial behavior, delinquency, period in prison, any history of violence or assault. Also, notes we should know details of any problem involving the law, charges or convictions. Social history. We ask about accommodation, finances, home activities, outside activities. Premorbid personality. The personality of the patient consists of those habitual attitudes, patterns of behavior, together with physical characteristics. To distinguish him as an individual to others and to himself. So to know the premorbid personality, we ask the patient how they would describe themselves or how others would describe them. To get more information about premorbid personality, we ask about his attitude to others, whether he is leader or follower, dependent, aggressive, sensitive, or suspicious. Also, his attitude to self, whether he is egocentric, selfish, and self-dramatizing, and we ask about his moral, religious attitude, standards, whether he is rigid or easy, or there is a religious beliefs. Also, we ask about reaction pattern to stress, mood, leisure activities, and fantasy life. Level of consciousness. There are two components, arousal, whether confused or drowsy. So this is related to brain stem, while awareness, comprehension, orientation is related to cerebral cortex. The appearance in mental state exam is very important, appearance and behavior. Clinically, if the patient younger than his stated age may be seen in histrionic personality disorder, while if he is older than the stated age, this may be seen in depression or chronic schizophrenia. Also, the body build is very important. If he is very tall patient, there may be chromosomal abnormality, while if he is very thin, we think about anorexia nervosa. If the body is picnic, we think about depression. If the body is thin, we think about schizophrenia. If it is athletic, so we think about epilepsy. If there is a weight loss, we should think about anorexia nervosa, physical illnesses, depression, anxiety disorder. While if there is an overweight, we must think about hypothyroidism, caution, medication side effects, or pregnancy. If there is an absent eye contact, we may think about paranoid schizophrenia or acute delusional disorders. If there is any neglect or decreased care, this may be found in dementia, schizophrenia, substance abuse, depression. Also, we come from the general appearance, we can see the tremor, abnormal movement, tattoo, or scar. The psychomotor activity or retardation may be a sign of depression or hypothyroidism or Parkinsonism. Also, the behavior may be guarded or uncooperative or childish. Inappropriate of dressing like long coat in summer, we should think about dementia, schizophrenia. If the dressing is brightly, so we think about mania. Drab colors, we think about depression. Oddity, usually it is related to delusion. Speech, we are looking for any spontaneous speech or only in answer to questions or to the point or past the point. So we are looking for any formal thought disorder. If the speech is very slow, we think about depression, dementia, hypothyroidism. If it is rapid, like prolixity or flights of ideas, we think about mania, hypomania, hyperthyroidism. Also, depressed and psychotic patient may show also an increase in the latency of response to question. If the voice soft, we think about obsessive compulsive personality disorder, anxious avoidant personality disorder. But if it is hoarse, this is an example of mania. Also, patient who speaks loudly may be manic, irritable, or anxious, while if it is very low volume, may be a sign of depression. The affect, which describes the emotional response to a particular situation, while the mood is a subjective emotional state over a period of time. We ask him, how do you feel in yourself and what is your mood? If the patient depressed, we should ask about suicidal thoughts or any attitude in the future. So the mood is subjective, longitudinal, and qualitative, while the effect is objective, cross-sectional, and quantitative. If we see omega sign, so it is a sign of depression. Usually in depression, the corners of the mouth are turned down and there are vertical furrows on the brow. While in anxious patient, we see horizontal creases on the forehead, widening palpebral fissure with dilated pupils. So the effect may be normal, may be happy, may be sad, anxious, angry, or indifferent. This is an example of different types of affect. It is better for the patient to rate his mood on a scale of 1 to 10. An example of affect, we can say the affect is constricted, sluggish, and inappropriate to content. Thought contents. This should include morbid thoughts and preoccupations, phobias, obsessional rumination, compulsions, rituals, and fears, overvalued ideas, delusion, suicidal thoughts, homicidal ideation. We are looking for any formal thought disorder like loose association or derailment, flight of ideas, tangential thinking, circumstantial thinking, or salad, pressure of speech. We are looking for any abnormal perception. Derealization is a subjective feeling of unreality of the surrounding, while depersonalization is a subjective feeling of unreality of the self. Also, other types of abnormal perception is illusion and hallucination. Hallucination is, roughly speaking, 70% of people with schizophrenia will experience hallucination. Auditory hallucinations are most commonly experienced by people with schizophrenia and may include either single voice or multiple voice as running commentary or third person or commanding hallucination. Cognitive state. This should be briefly assessed in every patient and related to his general intelligence. Disorientation can occur in delirium and intoxication. Typically, disorientation is first in time, then in place, and finally in person. Attention is tested by asking a patient to spell his name forward and backward. The patient can also be asked to name 5 words that begin with a given letter. Attention usually impaired in anxiety and depression. Examination or testing of concentration, usually by abstraction of serial sevens from 100, or ask the patient to reverse the days of the week. Memory. During history taking, we are looking for any memory problems. To assess memory, we should assess the immediate, short-term memory, recent, and remote memory. Immediate memory is tested by repetition of digits. In normal intelligence can usually repeat 6 digits forward and 5 in reverse. While short-term memory to be tested, we ask the patient to repeat 3 items, then to be asked 5 minutes later. Recent memory is an interval of minutes, hours, or days. Recent memory is tested by asking a patient what he ate for dinner the previous night and asking if he remembers the examiner name from the beginning of the interview, while the remote memory is tested by personal events in childhood. Cognitive impairment might affect attention, language, judgment, memory, reading, or writing, but it does not severely impair activities of daily living. Some forms of mild cognitive impairment can be temporary, indicate depression, anxiety, or stress as a reason. Other reasons, neurodegenerative disorders like Alzheimer, Lewy body disease, and Parkinson's disease. Imagine the abstract thinking by the ability of the patient to deal with concepts during the interview. Also, we can ask him about similarities like what are the similarities between the dog and cat. Also, we can ask him a famous proverb to explain it. Finally, we can say the abstraction either concrete answering or adequate abstraction or superior abstraction. Visual spatial ability, we ask the patient to copy a figure, example, interlocking pentagons. Dementia affects more than just the ability to remember things. It also can impact visual spatial abilities and skills. Several research studies have concluded that the visual spatial changes are especially prevalent in Lewy body dementia and Parkinson's disease dementia. To assess intelligence, we should ask first about general information. Example, who is the vice president, who is the governor, what is the state capital. But we must put in our consideration the educational and occupational state. Also, if the patient may be slow learner or poor scholastic achievement. Also, we can ask the patient a simple task and ask him to solve it. Then we can say that the intelligence either above average or below average. Judgment, decision making. During the course of the interview, the examiner should be able to get a good idea of the patient's ability to understand the likely outcome of his or her behavior. Judgment can be tested by asking the patient an example, what to do if you smell smoke in a cinema. The insight of the patient can be assessed by recognition of the illness by the patient himself, compliance with the treatment, and labeling of symptoms. Then we can say the patient is insightful or with partial insight or with lack of insight. About 60% of schizophrenic patients don't believe that they have any illness, which is an indication of poor insight. Poor insight and judgment was associated with schizophrenia and organic brain disease. Thank you for your listening.